We are live.
Good evening, everyone, and welcome to yet another class of iFocus Online. I'm Dr. Pranita Sahai. I'm the moderator for this session, and I would like to welcome our speaker, Dr. Garvita Dabas, who is working currently in Center for Sight and who will be teaching us about the basics of Phaco machine. So, as we all know, cataract is the bread and butter for every ophthalmologist, and so it is utmost essential that we know the first and most important thing, that is the Phaco machine. So we are here on episode 393 of iFocus and on the cataract module. So moving on to the introduction of our speaker, Dr. Garvita Dabas has done her MBBS from D.Y. Patil School of Medicine from Navi Mumbai. She's a gold medalist in her post-graduation, which she has pursued from the Muzaffarnagar Medical College and Hospital. Currently, she is a senior fellow in cataract and refractive surgery at Center for Sight Eye Hospital in New Delhi. She has received various awards for her paper and poster presentations in various conferences. She has authored over 8 journal articles and has delivered 6 instruction courses and over 30 presentations and lectures at various ophthalmic meetings of national and international repute. So I welcome Dr. Garvita Dabas for this interesting class on the basics of Phaco machine. Garvita, over to you.
Good evening, ma'am. Thank you so much for that lovely introduction, ma'am. I'll just share my screen for once.
Dr. Sai, please stop the share.
Is my screen visible? Am I audible clearly?
Yes, you're audible and the screen is also visible very well, Garvita.
Thank you, ma'am. We'll just start the session now, ma'am. It's very important to know your Phaco machine before you begin your Phaco journey. And thank you for the opportunity for taking this esteemed class in iFocus series. So I'll begin my presentation with an introduction to the Phaco surgery itself. Phacoemulsification was introduced by Dr. Charles Kellman in 1967. The story goes that he observed a dentist using ultrasonic energy to break down dental plaques, and which is where he conceived this idea that we could use it for cataract surgery, and hence the surgery of phacoemulsification was patented. The goal of phacoemulsification is to remove cataract surgery through small incision and to achieve rapid visual rehabilitation. This is an outlay of the entire Phaco machine. I will be taking a minute here. Phacoemulsification and fluid dynamics. What is Phaco? It is ultrasound energy which is used to break down and emulsify the cataract. Fluidics are important to counter potential heat buildup which occurs as a result of this ultrasound energy, and also to act against the repulsive action of the Phaco probe, and most importantly maintain AC. So in this diagram, which is an outlay of the Phaco machine, we have an irrigating bottle. We have a drip chamber which connects the irrigation line. This irrigation line has an irrigation pinch valve which controls the fluid motion through this line. The irrigation line goes into the ultrasonic handpiece and enters anterior chamber, which is the small white circle. This is the enlarged view of the same circle where we see the probe inside the eye. The blue line indicates the motion of the fluid. There is another line that we see attached to the handpiece coming out of it, which is the aspiration line. There is a pressure transducer here, which empties the line into the pump, and there is a drain that connects the pump and drains out the waste fluid. Ultimately, we have a foot pedal that controls all the motions as per the surgeon's requirement. We will be going into detail of each and every part of the machine. Beginning with the Phaco machine, it consists of a console, which is this screen that we see, foot pedal, a handpiece, which can be a phacoemulsification handpiece or an irrigation and aspiration handpiece, and their respective connections. Coming first to the console consists of all the controls and the functions of the machine. As we can see in the picture, This is a picture of a console. Here we can see all the options available. We have Phaco, Sculpt, Chop, Quadrant, Epinucleus mode, IA mode, Vitrectomy mode. We have aspiration rate, we have vacuum, we have power. We can even see the bottle height, which is 90 centimeters in this particular case. We have the values that have been entered by the surgeon. Coming to the foot pedal, this is an outline of the foot pedal. The phaco surgeon presses upon it. Position 1, irrigation. Position 2, aspiration. Position 3, phaco. Going into the detail of it, 0 is the first pedal position. There are 4 positions, 0, 1, 2, 3. 0 is inactive, which is the rest position. There is no activity at this point. When the doctor enters into the irrigation mode, which is pedal position 1, as we can see in the diagram, 1 stands for irrigation. As the pedal moves from 1, then mode 2, 2 is irrigation and aspiration. Mode 3 is irrigation, aspiration plus phacoemulsification. Now, one important rule here, irrigation is an all or none thing. Whereas level 2 and level 3, which is irrigation, aspiration and phacoemulsification, these are all incremental, which is the more you press upon the pedal, the power increases. So how do we deliver power via this foot pedal? In position 1 and 2, there is no phaco power. It is only in position 3 that you get a power proportional to the amount of foot pedal depression, which is called a linear control of power. This is an outline diagram of all the various available power modulations. One is phaco continuous, where there is continuous energy which is increasing as you are pressing down on the foot pedal. Second, phaco pulse, where pulses of energy are being delivered as you are pressing on it. Third is phaco burst, where a uniform amount of power is being delivered at an interval which reduces with time the more you press on it. I'll go and explore each one of them with you. Continuous power, phaco tip is continuously vibrating to provide constant power as suggested in this diagram. It is always on and there is no off time. Pulse mode, the frequency of the pulses is already entered into the system, but the amount of power per pulse depends upon the amount of foot pedal depression. What that means is the time is fixed, but the power is variable and it increases as you depress the foot pedal. Therefore, on time is equal to off time. Why? Because the time is fixed. What the advantage is? It reduces chatter of the nuclear fragments at the phaco tip and enhances followability. What is chatter? Chatter is a specific description of the tendency of vibrating phaco tip to push away material that comes in contact with. Since the phaco tip is vibrating, it repulses away the nuclear fragments. This constitutes chatter. Third is the burst mode. Bursts of full power are delivered, which is, as we can see in the diagram, full power is being delivered. However, the frequency depends on the foot pedal depression. That is, power is fixed here, but the time is variable. The advantage is it reduces the overall energy delivered to the eye. It enhances followability and grip and reduces the likelihood of corneal burns. This is just again for your revision, the phaco continuous mode, phaco pulse mode and phaco burst mode that we just discussed. There is another mode called a hyperpulse mode, also known as cold phaco, white star or micropulse. Here, on time is less than off time. Why? Because as we can see in this diagram, in this white star mode, pulses are delivered, but pulses are shorter than the traditional pulse. Therefore, energy that is delivered is very brief, only for microseconds, and it is interrupted by rest periods. And full ultrasound cutting ability is still retained. So most of the machines, high-end machines that are available now generally come with the white star setting. On the foot pedal itself, there are side kicks. Apart from the foot pedal, on the side, there are buttons where you can kick, and aspiration flow rate is inverted for some time and material is aspirated. Material that is aspirated is expelled into the AC. Now, this is not a continuous process. And when do you use it? For example, when you accidentally pull on the posterior capsule or the iris. So you can use this reflex button just so that the aspiration flow rate is inverted and the material gets aspirated without any damage. We'll now come to the irrigation system. So irrigation is your foot pedal 1 position. Irrigation comes for the fluid bottle that is at a height. The irrigation line supplies it via the phaco probe into the anterior chamber. This is foot pedal 1 position. What is the role of irrigation system? The irrigation system cools down the ultrasound tip. It minimizes heat generation. It prevents tissue damage and it maintains a stable anterior chamber. The role of gravity here is that the hydrostatic pressure is driven by gravity and that drives the irrigation system. Now a general rule is the general question is how high to keep the bottle. What is the bottle height? So approximately 11 millimeters of mercury pressure above the ambient atmospheric pressure is produced intraocularly for every 15 centimeters or 6 inches bottle height above the patient. What that means is bottle height is directly proportional to the height of irrigation to the patient's IOP. So ideal height is 3 feet or 90 centimeters above the eye level. In this diagram, we can see the irrigation line is supplies and also the gradient is created by the tip of the interplay of this negative aspiration pressure and the positive irrigation pressure. This pressure creates a path inside the eye for the flow of fluid, which is called the followability and drives the nuclear pieces in that direction. We will discuss this further in the next slide. So the standard bottle height enables a fluidic balance. What is a fluid balance? That is the balance between inflow, which is your irrigation, and outflow of fluid. Outflow has two components. One is the aspiration and one is wound leak, which is fluid leaking via your main port or your side ports. Both of the balance of inflow and outflow of fluid is required to maintain a stable anterior chamber and therefore also to protect the cornea and the posterior capsule. What will happen if there is too much of height? As you can see in this flowchart, increase in height can cause excess fluid in the eye, which can cause undue zonular stress. The more zonular stress will lead to fluctuations of the lens iris diaphragm, which will lead to irritation of iris, causing a miosis, and this, if continued for a long time, will cause repeated iris prolapse if pupil is small and the wound is large. So what are the special situations when you might need a low bottle height to begin with? Firstly, in cases of advanced glaucoma patients, there could be a risk of wipeout syndrome. So a lot of phacosurgeons prefer to operate such patients at low IOP settings. Third is painful phacoemulsification can be painful for patients with higher baseline IOP, larger anterior chamber depth or greater axial length. Also, high IOP during phacoemulsification can lead to fluid misdirection syndrome. Any kind of surgery can lead to fluid misdirection syndrome. This is an important point to remember here. In high myopes and vitrectomy eyes, low bottle height is preferred. Also, studies have suggested high bottle height is associated with increased Tresmet folds, greater anterior segment inflammation, and more edematous cornea when using phacoemulsification because it causes high IOP. Pseudo-exfoliation syndrome, again, there is already weakened zonules. Further, increasing bottle height can only increase the stress on these zonules. Also, posterior polar cataracts, which we already know have a pre-existing posterior capsular defect. For example, if we already see a defective posterior capsule on ASOCT, in such cases, we are expecting a PCR. So, in such cases, bottle height goes so as to not disturb the hyaloid phase. Phacoemulsification in patients with tamsulosin. Again, in such patients, we expect an intraoperative floppy iris syndrome. For such patients, low bottle height is recommended. So what happens if there is a PCR or vitreous loss? The first thing you do is bottle height should be lowered Why? Again, as I said, to prevent hydrostatic pressure forcing vitreous into the anterior chamber. Coming to the next part of our machine, which are the pumps, which constitute the aspiration system. Now that we've covered the irrigation and the control via foot pedal. Aspiration system. Aspiration system, the role of the system is to remove emulsified nucleus and cortical matter from anterior chamber. Also remove heat generated by the phaco tip, which is vibrating. Also, aspiration generates holding power for the surgeon. Nowadays, with the advent of more phaco direct chop and phaco chop techniques, all these techniques require a higher holding power. So this is a very important point, that the holding power is generated by the aspiration. This is a diagrammatic representation of aspiration, which is your foot position 2. Just to revise, this is a fluid bottle kept at height bottle, and then the irrigation line bringing the fluid into the anterior chamber via phaco probe. This is your aspiration line marked in red, which drives fluid from anterior chamber into the fluid pump and collects as a paste fluid. This is your aspiration line. All of this controlled by foot pedal. So there are various types of pumps available, which is peristaltic pump, there is venturi, there is diaphragm. The most common used are peristaltic pump and venturi. We'll go into detail of each one of them. Peristaltic pump is a flow-based pump. It is done by the means of rollers over which the aspiration tube is draped. So in this diagram, as you can see, they are group of rollers which are rotating, and there is this aspiration line over these which connect to the phaco probe. So every time, just like in a human gut, the peristaltic action occurs and there's pinching of small amounts of fluid. Similarly, in this pump as well, there is very small pockets of fluid are removed. Only a minute amount of vacuum is created. Every time a fluid from any part of the tubing is removed, in that area, vacuum is generated. Therefore, if the occlusion of the aspiration tip occurs, therefore, a large vacuum might build but occurs step by step as each pocket of fluid is removed. Therefore, we can say the vacuum depends on the aspiration flow rate, which is the amount of fluid exiting the going into the aspiration. What are the features of peristaltic pump? It has a slow buildup of vacuum, therefore offers a large safety margin. It is more controlled fluidics. Vacuum builds only on occlusion, and therefore surge is more. Why? What is surge? Surge is every time fluid is removed, vacuum is built. Suddenly, when there's a break of vacuum, the tubing comes back to its original size. So it aspirates certain amount of fluid. That causes surge. I will discuss it more in the further slide. It is very good for beginners, and here the nucleus has to be mechanically approached. This is a diagrammatic representation. This is a peristaltic pump. Phaco aspiration tubing is connected over the rollers. Pinch rollers compress the phaco tubing. There is rotation of the rollers and the fluid is drained into a drainage bag. This is a non-occluded phaco tip, as we can see in the diagram, and this is an occluded phaco tip. So here the vacuum is low and it builds gradually. In occluded tip, the vacuum can be high, but it will build again gradually. Venturi. What is the venturi effect? It is the swift movement of a compressed gas that creates a negative suction force, that is vacuum inside a closed chamber, and it is based on the Bernoulli's principle. So this is the compressed air, this is the aspirated fluid, and this is your phaco probe. So the vacuum is transmitted to the handpiece by the suction pressure caused by the compressed gas. The amount and speed of the gas will decide the level of vacuum. What are the features of Venturi pump? It is linear and rapid buildup of vacuum is seen even without occlusion, compared to peristaltic where occlusion was required to build a vacuum. Here, there's a good flowability of tissue. Nuclear and cortical matter can be easily attracted to the tip, which is again the flowability of tissue. Surge is less as vacuum is constant even on occlusion. So this is a small advantage of the Venturi pump. Rise time is fast, therefore safety margin is lesser. What is rise time? Rise time is how fast your vacuum builds. Then it is yes good for experienced surgeon, whereas peristaltic is good for beginner surgeons. This is a diagrammatic representation of the Venturi pump. Just for your revision, this is the flow of compressed gas. This is low pressure, high velocity, whereas this is high pressure, low velocity. This creates a vacuum. Vacuum causes, this is the cassette. Vacuum causes lift up of this gas, and Phaco aspiration tubing connected to the handpiece sucks the aspiration. Peristaltic pump vacuum levels, this is non-occluded and this is again occluded. Vacuum is high both, but it occurs, it is not as unpredictable as a peristaltic pump. What is vacuum? Once the aspiration port is occluded, vacuum starts to rise. What is the upper limit? It is set by the surgeon and the aspiration system continues to remove fluid till this level is achieved. Vacuum in the system provides a hold, and this hold helps us grip the nuclear fragments. So as I said previously, aspiration helps us provide a good hold over nuclear fragments. A small slide which is for the comparison of peristaltic and Venturi pump. Peristaltic, as we have discussed, is flow based, whereas Venturi is vacuum based. When peristaltic pump, vacuum is created on occlusion of Phaco tip, whereas in Venturi, vacuum is created instantly via the pump. In peristaltic pump, flow is constant until occlusion. In Venturi pump, flow varies with the vacuum level. In the peristaltic pump, it drains into a soft bag, whereas in Venturi, it drains into a rigid cassette. This is the rise time that we were discussing previously. This is a measure of how rapidly vacuum builds up once occlusion has occurred. So, comparing both Venturi and peristaltic, in Venturi, the rise time occurs fast, it is linear, and it depends upon the highest preset vacuum. In peristaltic, the rise time depends on the flow rate of the machine, because the vacuum in peristaltic depends on flow rate, and the higher the flow rate, the lesser is the rise time. Coming to the most important part of Phaco, it is the handpiece. How to control this handpiece, what are the parts of these handpiece, we'll discuss in detail now. This is the third part, or the foot pedal 3 position. Just to summarize, the fluid bottle, irrigation line into the AC, the aspiration line into the fluid pump and the waste, and this is the ultrasound power coming from the Phaco machine into the hand Phaco probe. This is our position 3, which is ultrasound. So what is the constituency of what does the handpiece constitute? So it has 2 lines, the aspiration line, the ultrasonic power line, and the irrigation line. The aspiration, irrigation, ultrasonic. Probe, this is our probe. The tip is made up of titanium. There is a transducer in the probe, which transducer is an equipment that converts your electric energy into mechanical energy. So there is a silicone sleeve over it, and there is the aspiration line is positioned coaxially to the irrigation line. These are the various tips that are available. We'll discuss each of them. Phaco power. So where does the Phaco power come from? It is generated by a vibrating piezoelectric crystals. They may be 2, 4 or 6 in number. They generally vibrate at a frequency of 28,000 to 60,000 Hertz, and they offer the cutting power of the nuclear fragments. This frequency is already preset for any individual machine by the manufacturer. What is a transducer? As I said, transducer is an equipment to convert one form of energy into another. Phaco transducer converts pulsed electrical energy to mechanical acoustic waves, can be of two types, piezoelectric or magnetorestrictive. The differences between the two are, for magnetorestrictive handpiece, the electric current induces a magnetic field. For a piezoelectric handpiece, it generates an electrical energy which translates into oscillations. Magnetorestrictive is less efficient, whereas piezoelectric is more efficient. Magnetorestrictive, it heats up more readily, and piezoelectric, it heats up slowly. It is heavier, this is lightweight. Magnetorestrictive is less cost, whereas piezoelectric is most costly. Magnetorestrictive is known to be unbreakable, whereas piezoelectrics are very fragile. Coming to each one of them, what are piezoelectric quartz crystal? They are certain crystals which, when compressed, produce electric current. Electric current can also cause crystal to contract. Applying currents to crystals at high frequency can cause them to oscillate at this frequency. The function is it converts the electrical energy to ultrasonic energy, which causes the tip to vibrate mechanically and fragment the nucleus. Coming to the magnetorestrictive ones, as we discussed, it is ferromagnetic lamellae surrounded by electric coil. The advantages it offers is that it has contact-free excitement, whereas in piezoelectric, we need to compress it. It can withstand mechanical injury and it has a longer lifespan. However, it has low rate of efficacy and there is increased amount of heat dissipation. So how do we modulate the power of Phaco? It depends on the stroke length. What is stroke length? It is the excursion of Phaco tip that is known as stroke length. This diagram, if you can see here, this is the position of tip at rest. Every time the tip moves forward and backward, this distance that it covers, this is called the stroke length. Generally, it is 0.05 to 0.15 mm, and for every individual machine, the frequency of vibration is fixed, whereas this stroke length may be variable. So every time we increase the power, we are not increasing the frequency, we are just increasing the stroke length to break down a hard nucleus. This is the frequency which varies between 28 to 40 kilohertz. These are some commonly used frequencies for various machines. So Phaco power is frequency multiplied by stroke length, which gives you a total Phaco power. And therefore, we can increase or decrease our Phaco power by modulating the stroke length. As depicted in this diagram, each stroke creates a mechanical impact on the nucleus, a cavitation or an implosion of the nucleus. It also creates a fluid and a particle wave, and unfortunately, as a side effect, it also creates heat because of the energy. So there are 4 proposed mechanisms that explains the cutting action of a Phaco probe. The jackhammer effect. Every time the Phaco probe hits the nuclear fragments physically, that causes a jackhammer effect. Second, by creation of an implosion. How? As the tip moves backward, it creates a vacuum and leads to an implosion. Third, generation of acoustic wave in fluid medium surrounding the tip. Acoustic waves are created around in a 360 manner in the fluid medium around the tip every time it oscillates. which further breaks down the surrounding nuclear pieces. Fourth, the torsional shearing action of an angulated tip. There are various types of tips available. So the torsional shearing action of angulated tip is seen in specially machines with torsional phaco, which is the tip has both longitudinal and rotatory movements. So what the drawback that heat is created, we'll see this. It can, every time the phaco tip moves, the heat is created. So a good fluid flow will increase heat dissipation, and there can also be slightly leaky incisions. But a lower power settings can decrease heat production. There is this cinch test that you can do in your practice. You can take a phaco probe, increase the step on the foot pedal 3, and just between your fingers you can check if it can singe your fingers. I mean, generally it is okay to the heat produced should be tolerable, but if you don't want to risk burning a patient's cornea, it is important to check intermittently. So these are the various tips that are available in the market. There are 0 degree, 30 degree, 45 degree, 60 degree, the various angulations of a phaco tip. As we move towards the highest angulation, which is 60 degree, the cutting power increases because of the angulation. However, the grip or the holding power reduces. So 0 degree has the best holding power, but 60 degree might have the best cutting power. We need to take a blend of both. The most popularly used are 30 degrees. Why? Because they offer adequate holding and cutting power, which is very good for both trenching and chopping. This is a titanium tip. Why titanium? Because it resists the fragmentation which can occur with brittle metals. So this tip is the titanium tip. This contains the transducer, and these are the 3 lines that are connected to a phaco probe, and this is the silicon sleeve over it. The various tips that are available are: number 1, Kelman tip. It is angled for increased cutting efficiency and improved manipulation. The first diagram here shows the Kelman tip. It is very ideal for hard cataracts and eyes with deep AC, but there is a risk of PC damage in shallow AC. Second is the McCool tip or the Alcon tip, where the inner sleeve is provided for added thermal protection. Third is tipped with aspiration bypass system, which is a tiny hole. As you can see here in this picture, there's a tiny hole in the needle which causes inflow of fluid into the needle from the irrigation sleeve, as suggested by these arrows, on occlusion. So it prevents sudden inflow of fluid when the occlusion breaks. Fourth is a cobra tip. It is base of macro tip proximally and regular tip distally. It can help in aspirate big pieces and emulsify within its walls, not just in AC. This is the silicon sleeve. It has 2 openings on both the sides for the exit of fluid, and ideally should be perpendicular to the tip bevel. Coming to the next handpiece, which is the irrigation and aspiration handpiece. So there are 2 commonly used aspiration, coaxial as well as bimanual. The first is coaxial, where the aspiration port is near the tip. It also has a silicon sleeve with 2 irrigation openings on either side of the central aspiration port. This is the bimanual system in the picture. This is the irrigating cannula. This is the aspiration cannula. It is the opposite. This is the safe zone cortex, which can be removed. And when you can reverse your hand positions to get the cortex, it is very efficient in removing the subincisional cortex. Both the probes are attached to different lines. One is the irrigation line, one is the aspiration line. The general size is 20 gauge, which can be inserted through a small side port. Followability. So what is followability? It is As we can see in this picture, removal of fluid from this, there are various eddy currents that are formed. So the removal of fluid from the anterior chamber can lead to formation of these unidirectional currents. Any loose material like small fragments or cortex, they can flow towards the aspiration port here, just shown here, creating an attracting force called followability. The higher the flow rate, the better the followability. So as we can see in this picture, the irrigation fluid is coming out from both the sides, whereas creating a followability channel at the tip of the aspirating port. As we discussed, the eddy current from the infusion orifice to the phaco tip creates area encompassed by these eddy currents known as zone of followability. So this is a picture representation of zones of followability, which is area around the tip, which is shaded in green. This area has good followability, whereas area around the incision, which is shaded gray, the main incision, it has no followability. Whereas the remaining area, which is shaded yellow, these area have poor followability. So to achieve removal of material from this area, you need to move your phaco probe just slightly, not to pull on the iris or the capsular axis, but you can maneuver your instrument to absorb the fragments in these areas. So what is compliance? Compliance is the property of the tubing to collapse or to deform under pressure. As seen in this diagram, when the tubing is occluded with cataract, it can lead to tubing loss, the collapse of the tubing. Compliant tubing collapses and stores energy. So, just as your occlusion goes away, the tubing comes back to its original position, causing an aspiration of sudden large amount of fluid. This is called post-occlusion surge. So, more the compliance, that is, more the property of the tubing to collapse, it will lead to more surge and less responsiveness from the system. Whereas the lesser compliance of the tubing, that is, the more rigid the tubing is and the more it retains its shape under pressure, it will cause less surge and therefore more responsiveness of the system. So, fluid will be taken up suddenly by the aspiration system, which may cause a temporary shallowing of the anterior chamber. This is called post-occlusion surge. In a peristaltic system and in comparison to a venturi system, we'll talk about both. In a peristaltic system, there is loss of occlusion causes vacuum to drop to zero. Then it will lead to permitting the aspiration tubing to regain its full pre-occlusion volume. This will draw in a greater amount of fluid and the surge that is experienced is bigger in a peristaltic system. In a venturi, however, there is already some amount of vacuum that remains in the tubing even when the occlusion is broken. This increase in volume will not be as large as a peristaltic system. Therefore, the consequent surge will be much lesser. How do you control surge? There are a few measures you can take from the point of occlusion to the rise of vacuum to the point of occlusion break followed by surge. This can be raise the bottle height so that there is more inflow of fluid, lower the flow rate, use resistant tubings, use smaller phaco tips so that the fluid aspirated is less, use larger irrigation ports and lower your vacuum settings. Some machines also offer pressure sensors that are incorporated into vacuum line to stop the pump as soon as the machine experiences a surge or occlusion. Venting. This is one mechanism by which we can prevent surge offered in some machine. In the diagram first, A diagram, we can see the probe is free, there is no occlusion. This vent valve is closed and the tubing is normal, and the peristaltic pump is rotating, correct? However, in picture B, we can see the tubing is occluded and this valve is closed. Hence, as a result, in this particular area of tubing, there is a vacuum buildup and the tubing has collapsed. In the diagram C, as soon as the occlusion is gone, the valve will open momentarily, such that the fluid will enter from the valve and the amount of fluid aspirated from here is less. It provides a fluid air to overcome the collapse of tubing and prevents the withdrawal of fluid from AC and hence reduces a surge. So this is one of the mechanisms we can use to prevent the surge. That's all about the Phaco machine. I hope I have covered most of the important aspects and areas of all the parts of the machine. I tried touching upon the clinical aspects, but however, they will be, I believe, covered in the later classes.
Thank you, Garvita. That was a lovely presentation with all the basics of Phaco machine were really very well covered. So I would also like to welcome our uh, our participants for the class today. We have Dr. Obinam, who is a second year postgraduate at Guru Nanak Eye Center, Maulana Azad Medical College. We have Dr. Ishita and Dr. Tulika. They are DNB fellows at Center for Sight Eye Hospital. Uh, can the residents and the postgraduates switch on their cameras? You have a lovely opportunity to ask questions to Dr. Garvita. If you have any questions, you can shoot your questions to Dr. Garvita. She'll be more than happy to answer your questions. Hey, Obinam, you have some questions. Are you doing Phacos currently?
Yes, ma'am.
Okay. So which machine are you using for surgeries?
Ma'am, Stella Elite more often.
More often. And the other machine that you use is
Centurion.
okay. So are you aware of the mechanism on principles on which these two machines work?
Yes, ma'am. Like Centurion works on the peristaltic pump that ma'am has just told us, and
Yes.
Stella Elite works on the Venturi pump, ma'am.
And you're operating on the Venturi pump more common than the peristaltic?
Yes, ma'am. Yes, ma'am. Ma'am just told ki Venturi is for more advanced like surgeons. She just told that because rise time is more. So like
graduate and you're already an advanced. You're working on
no,
advanced
no,
machines. So
not like that. Like
okay. So anything that you want to share based on your comfort level? Because usually what is advised is for beginners that if you start on peristaltic machines, you're more comfortable because the machine works at a slower pace compared to Venturi. And hence the chances of complication are less with peristaltic compared to Venturi. So have you noticed any difference in the two machines in your complication rates? They appear to be almost the same.
yes, ma'am.
Okay. Okay. So, anything, Garvita, you want to ask Obinam? Now you have some students, you can ask them questions.
All I can add is I don't have particular questions, but I can add that Phaco is a very important topic and the machinery of Phaco is often ignored. And it is very important when you're beginning your Phaco journey, it is very important to understand how the machine works. Only then will you able to manage your parameters. Like every surgeon knows what setting to keep for Phaco, for chopping, for quadrant removal from epinucleus. But unless and until you don't know your basics, how does the fluid move? How much vacuum is created? When is it created? What pumps are used? So it will be very difficult to blindly keep the parameters and not be able. You will not be able to adapt to different machines as you proceed.
Okay, ma'am.
So Garvita has very beautifully told us about the vacuum and aspiration and the functions of everything. So let's ask Vinam that once you see occlusion coming up on your Phaco machine, when you're doing a
Yes,
Phaco,
ma'am.
often what you see is occlusion starts coming. So what is the next step that you do?
Once occlusion is there, because vacuum is created, so like ma'am, while doing phaco, you mean?
Yes, while doing Phaco, say you are eating up a piece and you are seeing occlusion, and in the anterior chamber you see clouds forming, or there is fluffy matter rotating and you're not able to eat up the piece. So in such a
Yes, ma'am.
situation, what do you do?
Uh,
Which parameter would you like to change at that point?
bottle height.
Garvita, would you like to help her? What are the parameters that need to be changed in that setting at that point?
You need to first take a look at your vacuum. If your
Yes.
tip is occluded, and that means the vacuum is building up. Suppose
Yeah.
you're working, let's say, on a peristaltic machine. So when your tip is occluded, your pump, you listen to that turn, turn, turn type sound that comes every time you hit an occlusion. So you have to make sure the vacuum is okay, and then you can proceed from there.
So what
Okay,
I
ma'am.
would like to add is, so basically when you're trying to eat up a piece and you have a continuous occlusion sound and it's not eating up the piece, you also have to look at your ultrasonic energy that you're using. So maybe you're using a lower power for a very hard cataract. So you need to increase your phaco energy as well. And if even after increasing the energy, still there is an occlusion, you can remove your phaco handpiece outside the eye, flush the needle tip. Sometimes the needle tip gets occluded or blocked with your pieces of nuclear fragment. So flush the tip and then go in again and start again your phaco with an adequate phaco power. And even if by increasing your torsional energy, if you're not able to emulsify the nucleus, you're still getting an occlusion. In the advanced machines like Centurion, you also have an option for intelligent phaco. So you can even switch on an IP, which gives you an additional option to use longitudinal phaco as well, in addition to the torsional phaco, and that can take care of hard cataracts, and that occlusion can break. So if the torsional is not just enough to break your nuclear fragment, the longitudinal will also add up and you will be able to emulsify the nuclear fragment. So once you're getting a continuous occlusion, see what is wrong, whether you are using a lower power or your needle is blocked or you need additional longitudinal force to break that nuclear fragment. Okay.
Yes, ma'am.
Okay. So Tulika and Ishita are also there. Tulika, do you have any questions for Dr. Garvita?
Yes, ma'am. Good evening, ma'am. Thank you, ma'am, for such a lovely presentation. Ma'am, I wanted to ask you, can you please repeat, like, what are the situations in which we might need to raise or depress the bottle height?
Generally, the bottle height is kept at 90 centimeters above the eye level. However, if you have cases which I discussed previously, like patients with advanced glaucoma who are at a risk of wipeout syndrome, we don't want to work at a high IOP or a high pressure system there. So can reduce the bottle height in eyes who are previously vitrectomized, or in patients with high myopia or pseudoexfoliation syndrome. In such cases, like in pseudoexfoliation, there's already the zonules are weak. So in such cases, we don't want rapid fluctuations in AC or high pressure in the eye. So in such cases, it's ideal to operate at a lower bottle height as compared to the normal phaco in normal patients.
Yeah. In addition to that, also when you're operating posterior polar cataracts, where you're expecting your posterior capsule to be either fragile or already having a pre-existing dehiscence, in such situations also you use a low bottle height. Okay. So you reduce your bottle height in posterior polar cataracts as well. And as Garvita has already highlighted, wherever you are expecting a zonular weakness or incompetence. In such situations, you reduce the bottle height. So subluxated cataracts are also another condition. When you're operating on subluxated cataracts, you better reduce the bottle height in such situations. Okay? Because you
Okay,
don't
ma'am.
want to further damage the remaining zonules. Okay.
Yes, ma'am.
And when to increase the bottle height? Garvita, do you want to specify anything? So whenever you are basically your chamber is becoming shallow, okay? Whenever you're having a shallow chamber, that is when you want to increase the bottle height. Maybe your aspiration and irrigation are not matching, and that is when you want to increase the bottle height. Okay?
Thank you, ma'am.
Thank you.
Thank you.
So Ishita, are you there? Any questions, Ishita, that you want to ask? Or Garvita is going to shoot questions to you? I think she's already scared and she's not. Are you there, Ishita? She's not willing to speak. Okay, I think that was a really wonderful class. And we have, as you have already said, it is very important to understand your Phaco machine very well and all your parameters so that you know when to do what. For example, if you're trying to approach a piece and the piece is not coming towards you, what you want to increase is your vacuum. When you're holding on to a piece and you're trying to divide it and chop it, and the piece is getting slipped,
Hello.
what you want to increase is your aspiration.
Aspiration.
Yeah. And when you're trying
Hello.
to
Hi, ma'am. Can
Yes, Ishita. I think Ishita is back there.
you hear me?
Yes, Ishita, we can hear you very well. Welcome to the class.
Hello.
Can you hear us?
I don't think she can.
Yeah.
Hello, ma'am. Can you hear me?
Yes. Do you want to ask any questions?
Yeah, ma'am.
I think there is some connection issue. So, yeah. So what we were discussing is if then you're trying to eat up a piece and emulsify a piece and you're not able to do and you have continuous occlusion, then check your ultrasonic energy Phaco power settings. So these are the three things, and the whole Phaco is an interplay of vacuum aspiration and torsional power as well as the irrigation. So understanding that and using it in an appropriate way will give you the best outcomes. And with that, I think we have come to an end of the session. And at the end, I would also like to invite.
Yes, ma'am. I would like.
She is adamant on asking a question. Yes, Ishita, you have something to ask? Please ask. Go ahead. I think there is a connection issue. Okay. So yeah, so to end, what I would like to invite all the students who are attending the class to the physical iFocus that is going to be organized in the month of June from 9th to 16th of June in Hyderabad. Dr. Santosh Navar has been doing a great job by organizing these classes for, I think, almost a decade now. And it's a really interesting class with a lot of physical classes as well as hands-on training and sessions that are organized on various equipments for which you can enroll. There are limited seats for 300 candidates only, and the registrations are open. So if you're interested, kindly register for these, the Physical iFocus 2024. With that, I would like to conclude. Thank you all for joining this class, and thank you, Garvita, for this wonderful session.
Thank you, ma'am. Thank you for this opportunity.